All right, let's dive right into the fascinating world of multifetal pregnancies. Today we're going to break down how doctors manage the unique challenges of carrying twins, triplets, or even more, and we'll be using the official guidelines from the American College of Obstetricians and Gynecologists to do it.
Let's kick things off with just one number that tells a huge story. Get this. Between 1980 and 2009, the rate of twin births in the U.S. shot up by 76%. That's not a small jump. That's a massive shift in a really short amount of time.
So, you've got to ask yourself why. What happened? What could possibly drive such a dramatic rise in multiple births? Well, the data points to two really clear things happening at the same time.
First up, there was a big shift in maternal age. Women started having kids later in life, and that's an age when the body is naturally more likely to release multiple eggs at once. And second, the rise of assisted reproductive technologies, like IVF, which also really boosts the chances of a multifetal pregnancy.
Okay, but let's say a multifetal pregnancy is confirmed. There is one piece of information that becomes absolutely critical for managing it safely. And you know what? It's probably not what you're thinking.
It all boils down to this. It is not about the number of babies. It's about the number of placentas. This concept is called chorionicity, and it is the single most important factor for figuring out the risks of the pregnancy. And the absolute best time to figure it out is with an ultrasound nice and early in the first trimester.
I love this analogy because it explains that difference perfectly. So, think of dichorionic twins. That's the ones with two placentas. They're like living in two separate houses, and each house has its own kitchen. They've got their own resources, no problem. But monochorionic twins, they share one placenta. They're stuck in the same house, sharing one kitchen, and that's where the competition for resources can lead to some really unique problems.
And this distinction is just so important. Because while all multiple pregnancies are considered high risk, that shared house in a monochorionic pregnancy, well, that brings in a whole other level of potential complications.
Now, one of the biggest risks right across the board is preterm birth. And wow, just look at this chart. It shows you exactly how dramatic the difference is. For a single baby, the rate's around 8.2%. But for twins, it skyrockets to over 60%. That is a truly staggering leap.
This quote from the ACOG guidelines really drives the point home. Women carrying multiples are 6 times more likely to deliver preterm, and an incredible 13 times more likely to deliver very early, before 32 weeks. And that right there is why these pregnancies need such specialized care.
And yeah, the risks don't just stop there. For the mother, you're looking at a higher chance of things like preeclampsia and gestational diabetes. And for the babies, there are serious risks like fetal growth restriction. So with such a crazy high risk of an early arrival, the next logical question is, okay, what can we do about it? What interventions actually work to prolong the pregnancy and keep those babies safe inside for as long as possible?
And here is where the evidence might really surprise you. ACOG is crystal clear that a lot of the interventions people assume will help, the things we hear about all the time, well, they just haven't been proven to be effective in studies.
So we're talking about things like routine bed rest or a preventative cerclage, which is a stitch to help keep the cervix closed. Not recommended. Same goes for tocolytics, which are drugs meant to stop contractions, or a pessary, which is a supportive device, or even progesterone. They've all been studied, and the data just doesn't show they work for preventing preterm birth just because it's a multiple pregnancy.
So let's circle back and really focus on those monochorionic twins, the ones sharing that single placenta, because this is where some of the most complex challenges pop up. We're calling this section When Sharing Causes Problems. Okay, the most well-known complication here is something called twin-to-twin transfusion syndrome, or TTTS. Because the babies are sharing blood vessels in that one placenta, the blood flow can get all out of whack. One baby, the donor, ends up basically pumping too much blood over to the other baby, the recipient.
And this isn't some super rare thing. This serious condition affects about 10 to 15% of these shared placenta pregnancies. That's a really significant risk, and it's exactly why these pregnancies are watched like a hawk.
To manage TTTS, doctors use this 5-stage system. It's called the Quintero staging system to track just how severe it is and figure out what to do next. This whole system is why ACOG recommends screening ultrasounds every 2 weeks, starting all the way back at 16 weeks, just to catch any early signs of trouble.
So all this careful monitoring, all this risk assessment, it's all leading to a very carefully planned delivery. And that brings us to our final section, the finish line. The timing of that delivery is based almost entirely on that key factor we started with, chorionicity.
This table lays out the whole game plan perfectly. For uncomplicated dichorionic twins, the ones with separate placentas, the goal is to get as close to that 38-week mark as possible. But for monochorionic diamniotic twins who share a placenta, you can see the recommended window is earlier. And for the rarest type, mono-mono twins who share both the placenta and the amniotic sac, delivery is planned even earlier to balance all those growing risks.
And that leaves us with this final, kind of big picture question, doesn't it? We started this whole thing by seeing how technology helped cause this boom in multiple births. So as that science keeps advancing, how do we, as a society, continue to balance that incredible dream of building a family with the very real, very complex medical issues we've just walked through?